Welcome to Diagnosing Dx, the podcast giving diagnostics the platform it deserves. While therapeutics and devices often take centre stage, diagnostics is the engine driving precision medicine. I'm your host, David Philby, and each week we spotlight the innovators, breakthroughs, and real-world challenges shaping the future of DX. In this episode of Diagnosing Dx, I'm joined by Tara Maddala, statistician, founder, and diagnostics veteran whose career spans Genomic Health, Grail, and now her own ventures, Pandora Bio and Tiger Team Bio. We explore how the truth-seeking culture at Genomic Health shaped her approach to building and advising early-stage companies, while mental health diagnostics is decades behind, and what it really takes to align technology, clinical design, and people for success, while cutting through the hype around AI in diagnostics. Welcome, Tara, to the podcast this week. Absolutely great to have you on. How are you?
I'm doing great. Thank you for having me on this podcast and to basically talk about stuff that I love to talk about. So thank you.
Well, that's a great start, isn't it? If we're going to enjoy the conversation, we should have a bit of fun with it. So we've got quite a lot to unpack because I love where you are in the industry and how you're supporting early stage companies achieve their growth goals and hit their milestones. So your perspective is going to be awesome on objectively, but and also specifically within the diagnostic space. Before we get into that, it would be great to hear an intro and a background sort of to you, your career, what you focus on, and what you're doing now.
Yeah, sure. So I'm Tara, and I am the founder and CEO of Pandora Bio, which is a mental health startup to empower students, young adults and students on their mental health journey. That's a more recent development. I'm also the founder of Tiger Team Bio, which is a consulting and advisory firm that's focused on genomic diagnostics and devices. I started out my career in therapeutics, and then after that, got started at Genomic Health, where I actually built my entire foundation of how I think about developing genomic diagnostics, and learned a lot from many of the pioneers in this space, and they pretty much wrote the playbook of how to do this. And I had the opportunity to translate that at Grail, where we were working on this huge problem of early cancer detection for multiple types of cancers. And there I also not only got to apply that playbook for clinical development of products, but also learned a lot. It was an incredible place to learn about technology and learn from others who are leaders in the space. And then since then, I've been consulting for biotech companies.
Wow. Quite a lot to unpack there, but I wanted to take that back to the first thing you mentioned in terms of the Pandora Bio. Mm-hmm. So what is Pandora Bio? Give us a bit of insight into that.
Yeah, so it's a tool that is that collects data, and those data are passive and active data. But the idea is to use biomarkers and the biomarker to predict changes in mental health, and then not just predict the changes in mental health, but also help people with get access to resources. And it comes from this idea, longstanding interest that I have in mental health. I've spent 20 years working in mostly in cancer genomics, and we help patients make better treatment decisions in cancer based on information about their own data, like at Genomic Health. We help patients with early detection, like the work that I did at Grail. But we don't have any of those things in mental health. And from a personal standpoint of a family member who struggled with mental health, and then also as a family struggling with that, I felt like there's got to be a better way. And it felt like mental health was, a couple of decades behind. So then I got to thinking, how can I make a difference in that space? The years that I spent working on biomarkers to detect these changes and help patients with information about themselves, I thought the best way to do that was to look at the social and behavioral biomarkers that are indicative of changes for mental health. And so Pandora Bio is the I I hesitate to call it an app, because the app is like the front end to collect the data. And that's how, young people, Gen Alpha, Gen Z, they're always on their phones, right? So it's a way to get passive and active data and meet them where they're at, get those biomarkers, feed them through algorithms that then predict changes, and then empower them by giving them not only information about changes in their mental health, but also empower them by giving them personalized resources based on their identity, based on their preferences. Maybe not everyone wants to go to a therapist, right? Maybe not everyone wants to have a peer support group, but maybe they want an online resource. So we pair that with resources so that they get help sooner.
Wow. So this is something that you're really
Mhm.
passionate about, that
Yeah.
you've gone out there and started from the ground up.
Yep. Yeah. With colleagues that I've worked with in the past from the genomic diagnostic space, because we're, again, like I mentioned earlier, the genomic health playbook translated to Grail and other companies. Similarly, I feel like that this entire playbook of how to develop a product with true clinical evidence could be translated to the mental health space.
That's super interesting.
Yeah.
And then you mentioned your consultancy now.
Mhm.
What's the consultancy focused on? What's the sort of part of the industry that you're servicing and helping the most?
Yeah, so that's more aligned, I think, with the work of the past 20 years, which is working in genomic diagnostics and devices. So largely anything that would go to CDRH at the FDA, or outside of the FDA if it would go through like the MolDX pathway for reimbursement. But the ultimate goal of what we do is we think about, well, what's the best fit for the technology and the clinical unmet need? And then if you identify that, what is, starting with the end in mind, what is the regulatory and reimbursement pathway for that technology and that clinical unmet need? And then moving backwards, like from there, what is the analytical and clinical evidence that you're going to need to be successful at getting that reimbursement and getting through regulatory for that?
Wow. So what stage is your consultancy typically working with companies? When are you brought in? Because if you're working backwards to that effect, earlier the better is my assumption. But in reality, as if that happens, what's typically the point where you're asked to get involved and getting involved in companies where you're seeing the most benefit?
Yeah, so it's a great point. Earlier is better. Oftentimes I don't get pulled in earlier. I get pulled in after maybe um, a lot of work has been done and a lot of maybe cash has been burned on going down maybe paths that wouldn't have been ideal in terms of the technology doesn't meet the target performance requirements for that clinical unmet need, or maybe the clinical unmet need wasn't defined very clearly, or maybe the amount of money that they have to get to a product that's reimbursable and would get through regulatory. Maybe it requires FDA approval and they don't have the money for that kind of runway. And so we need to pivot to something that they can achieve with the money that they have, with the technological specifications they have, to meet something with a clinical unmet need. So I would say most of the time it's not at that very early stage. And it's more like pivoting and adapting to what they've done already and identifying how we can best utilize the funds they have so far.
Yeah, interesting.
Yeah.
The you mentioned the foundations of your process to bringing diagnostics to life and genomic diagnostics to life is
Hmm.
is very much grounded in your time with Genomic Health, right? And
Hmm.
the
Hmm.
almost 10 years that you spent there.
Hmm.
What what did that environment and how that company came to life, what did it teach you in terms of sort of the principles or that you still use today? Because it was a really important point that you mentioned,
Hmm.
but what did you mean by that? What's so strong about the foundations that Genomic Health gave you that you still
Hmm.
use and rely on today?
Yeah, that's a good question. So you had Kim Langone on one of your other podcasts, and she talked about like the culture and the culture of like leadership and feeling valued. We had several values I think we had 4 values. One of the core values there was the value of truth seeking. And I think that's something that really helped propel genomic health. And it was a startup when I worked there also with with Kim Langone. I wasn't as early as she was, but yeah, I started there pretty early, and really from the very beginning, we would have cross-functional members of teams really vetting the data carefully and thinking through how could we have been fooled by our own results, and thinking about bias and confounding, and always in those meetings, it was always like patient first. We need to be truth seeking because when we put something out there, it has to be accurate because in the end, we're putting patients first. And so, we didn't have silos with the data. We shared the data, and then we were all thinking about like the biologists would be thinking about the mechanisms of action, and the medical folks would be thinking about how would this be used by the physician and the patient, and is it giving useful clinical information to help actually make decisions? And the statisticians would be thinking about, how could we be fooling ourselves with this data or this result? Are there biases that when we put this out into the market, then it will, still perform the way we expect it to perform? So I think that quality of truth seeking and really sticking to the scientific method was something that was a real foundation that I like to think I and others who work there carry it forward to the companies that we work with in the future. I will say that I have sometimes been at companies since then where we'll sit around a table and I oftentimes hear this we hope it will turn out this way. And I love to say hope is not a strategy. In fact, I even gave a talk at a statistical association conference that title hope is not a strategy. You really need to think about what the data and whether this is really this is real or you're fooling yourselves. So I would say that's one.
In that
I can
sort
go
of,
on and on.
I'm sure, I'm sure. There's another podcast for that if we want to do it. But when you're in an environment where each department's work is transparent and
Mhm,
shared, and you can,
mhm.
is does that create an environment where departments are encouraged to critique or question other departments, not conclusions, but maybe statements? And does that create animosity at first? I'm just sort of playing out in my head because I sort of feel that if you start that environment, it's quite hard. But actually, if you persevere and people see that we're actually doing this for a greater good and the end purpose, the patient, actually, when somebody critiques me, this is that's data in itself. That feedback I'm getting from someone else's perspective of that actually I should look at something slightly different becomes incredibly powerful. And actually, a company that allows me to get too much into my own conclusion can be really dangerous, right? And that we see that across in companies all the time. But was it that kind of environment where people could speak openly and question each other, but actually you'd got to the point where nobody took it personally anymore? It was like, we understand why you're doing that, and actually that's a really great question. I appreciate that. At Alevra Consulting, we focus on DX only, supporting early stage and growth companies achieve their milestones by solving their biggest talent challenges. Have you ever suffered from working with a talent partner who was either life sciences or med tech and dabbling in diagnostics? Well, no more. Work with a diagnostics specialist talent partner.
Yeah, again, that's a good point. I feel like it's a mindset. It's a mindset of folks to be adaptable versus like a fixed mindset. If you have this adaptable mindset, then you know that, okay, if you hit a wall in one direction, then you know that, you say, okay, well, maybe I should be thinking of going to another direction, right? But you know, I'll give you another quote. I love quotes, by the way. You're going to figure out that I love quotes. But I heard this great quote the other day, that survival of the fittest isn't the strongest, it's the most adaptable.
Okay.
And I would say that, like, that was one of the things that again, I felt like Genomic Health did well. You think about a lot of these companies and especially in genomic diagnostics, are focused on developing tests that have like a yes, no answer, right? Yes, you have signal of cancer. No, you don't.
Right.
Or yes, you will respond to this therapy. No, you won't. And at Genomic Health, I remember I was working on the Oncotype DX prostate cancer test, and we were, a lot of the feedback was the urologists were saying, well, we want yellow light, I'm sorry, not yellow, green light, red light. Yes, do the surgery, no, don't. And and yeah, ideally we wanted that too, right? It makes everybody's lives easier if you can give that kind of information. But when we did the analysis and we looked at the data, we thought, well, what's the most accurate representation of the information that's clinically meaningful? And it didn't lend itself to red light, green light. We had to create a different type of report that was still giving them useful information and was still accurate. And I think it's that kind of like, if you keep an open mind in those cross-functional meetings to, really the scientific method, look at your data and see what it can and can't do. And then, keep that kind of adaptable mind, then you come up with successful products. So I would say, I don't know if I fully answered your question, but I don't know. That's how I think about it when I reflect back on my time there and then my time since then at different companies where I think they have this fixed idea of what they want, and it's sometimes hard to move people.
Yeah, that's super interesting. I think I recently recorded an episode which will be out soon with a commercialization
Mhm.
expert, and
Mhm.
um, the way he was explaining it in terms of, yeah, this is where your product is, but we have
Mhm.
so many options to try and turn this into a business. You shouldn't be
Mhm.
thinking that you should just be selling this as a diagnostic and it's suddenly going to make money as soon as you
Mhm.
employ a sales team. That's just not going to happen. We have to have options towards an end goal, and what that end goal is
Mhm.
a viable business that will survive. So yeah, super interesting. I had a question before we sort of get into the current market.
Mhm.
You were in therapeutics initially. What drew you into the diagnostic side, and your genomic health being your first dip into that? What was the initial draw?
Yeah. So I spent about 5, 6 years in therapeutics doing drug development, and the process is very standard. It's you go through the FDA, and there was only certain methods you could use. So it was just it. After a few years, it started feeling like I was just doing the same thing over and over again. And then I got a call about from someone at Genomic Health, and I wasn't looking to leave, but this concept of being able to use I'm a statistician by training. I don't even think I mentioned that in my background, but I'm a statistician by training. They called it statistics back when I went to school, but now the department has changed the name of the degree to statistics and data science. So I'm a data scientist as well, I'll say. But you just using more advanced new methodologies because, well, that was one reason. There are a couple of reasons. One is the new advanced methodologies because in the genomic diagnostic space, it doesn't necessarily go through the FDA. And so there were all these and it wasn't always based on randomized clinical trials, right? So there were all these new data, these new study designs that we could run. There was more cutting edge analysis that we could do. So from like a technical standpoint, it was pretty exciting.
Mm.
From a personal standpoint, my father struggled with type 1 diabetes and heart disease, and he died pretty early, actually when I was still in college. And um, my entire childhood, he was always trying to find He tried all these different therapeutics. They would give him certain drugs, and they would always have side effects, and they didn't always do, work as well as he would like them to work. So then he was always looking for other like ways to personalize his treatment, with homeopathics and things like that. And so this concept of personalizing treatment and personalizing decisions, like he was
Yeah.
looking at his data. He was also a statistician, and so that just appealed to me from a personal standpoint, like not just putting out more drugs for people. And this was back in like 2006, so this was at the forefront. This is the very beginning of this personalized medicine revolution. But that just made me really excited to just work in that space.
It feels like there's been incredible amounts of success and growth in personalized medicine, and yet
Hmm.
still so much further that remains to be seen, right? It feels like that. I think we might look back one day and go, wow, we were still so early on, in theory. Do you agree?
I don't know. I'm thinking about that, because I have seen so many advances
Yeah,
over the past 20 years. Yeah, maybe I need to be more forward looking. I don't know. But yeah.
yeah.
I mean, I do think in terms of um AI type of stuff, that excites me. I would say over the past 20 years, we've gone from like again, my time at Genomic Health in the early to mid, like, okay, 2006 to 2015 timeframe, where we were focused on statistical modeling, and we would always talk about machine learning modeling. And
Mm,
then starting in, around 2016, when I moved over to Grail, we started talking more about machine learning modeling and then AI. And I feel like in the last 5 years, you hear almost every pitch deck and every publication or press release says, our AI model this, our AI model that. And we truly haven't, for the most part, gotten to AI modeling in this space, for these tests. So yeah, I see the future as possibly being, utilizing that type of modeling to build products.
mm. So let's talk about the market objectively then. Where do
Hmm.
you, because you're getting involved with early stage companies as yourself, as a consultancy, as a group in your consultancy. Um, what's your objective take on the market at the moment and the challenges and opportunities that we're seeing in diagnostics and genomic diagnostics?
Yeah, so I think uh I think it comes down to like every company has to get maybe three things right. The technology, like de-risking the technology along the way, and understanding, like doing the correct due diligence up front to set themselves up for technical success. I think the second piece is like the clinical side, right? Doing the right experiments with the right populations of patients early on, so you don't take yourself down the road, the wrong road. And then the third is like the people, like adaptability throughout. And we talked a little bit about that. Like, what does adaptability look like? Finding the right problem to solve for that technology and continuing to adapt to the results you see. I think companies will generally get one or two of these, do those well, and maybe struggle with, one or two. So I would
Mm.
say, if you could help shore up, if we could help, I should say, if we could help shore up one or two of these and help them, then I think they could, lead to success sooner.
When you talk about due diligence,
Hmm.
what do you refer to exactly? Are you looking at stuff in terms of is there actually an unmet need? What is the market opportunity at the end of this? Or what other sort of types of due diligence are you saying right at the start that people need to be focused on?
Yeah, so a couple of, I would say I'd bucket that again into maybe the first two, the technology and the clinical side. So on the technology side, I mean, one kind of simple example is, um, let's say that you have a technology that a sequencing technology where you think you need you're developing a test for a clinical application where you need high sensitivity. Okay. And your technology is maybe low depth sequencing, and you want to, and your ultimate goal is this, high sensitivity. Well, in order to get high sensitivity, maybe you need to sequence more deeply. So understanding from the beginning, doing that deep sequencing and then downsampling to see where does your signal level off for this particular application, so you can pick the right sequencing depth. It's a very simple example, but it's a flavor of the kinds of things I've seen where in the very beginning, figure out where your signal tops off for the clinical application you're considering.
Yeah.
Um, on the clinical side, this is a soapbox of mine, which is that if you're going to develop a product for a particular clinical use case, you don't want to use convenience samples. And a good example, this is another like going to be extreme example, but I have seen flavors of this. So I'll go through like an example in a clinical context. So let's say that you're working on a lung cancer test, okay, to detect lung cancer. We know that for lung cancer, there are screening guidelines that say if you're a high risk individual who has a certain pack year history of smoking and a certain age, over 55, 50, I can't remember, 50 or 55, then you should be screened with a low dose CT annually. But only about 6% of individuals who should be screened actually get screening. And so, many companies are thinking, well, if we can increase um, the screening for these patients, then they will detect early stage. And we know that screening using LDCT detects early stage cancers, right? So what kind of test do you need for that kind of scenario? You need a high sensitivity test that gives you a high negative predictive value, so that we say, if you get a negative result on our genomic test, you have a very small problem, less than 0.1% chance of having lung cancer. And so for that type of test, if you're doing the development, right, let's say that you get you have a great KOL and they have all these lung cancer specimens. So you say, okay, I would like to get blood from all these lung cancer patients, but they're all stage 3, 4. And then you say, well, I've got this biobank with all these normal, healthy patients, and you get those specimens and then you compare them. Your model might look really great, right? Because it might look great in distinguishing lung cancer from non-cancer. But there are all kinds of issues with that. One is that they came from two different institutions, the cancers and the non-cancers. The non-cancers didn't have all these confounding conditions like, COPD or inflammation, or all the things that come with smoking. And your cancers were mostly late stage. Well, what we're trying to detect is early stage. So while you have a great classifier of the difference between the two, it could have just been a classifier of the source of the samples, because there was some sort of way that they were processed at the two different places. So by getting convenience samples not in the intended use population and not collected consistently between the two groups, you could be sending yourself down like a completely different road, thinking, oh yes, we've discovered the markers, we've trained our algorithm, and we have great performance. And then you're actually nowhere close. You're like, you've gone down the entirely, you've wasted your time, you wasted money on samples that were not useful to you, and you basically created a great predictor of source of where those samples came from. So that's an extreme example. I don't think anyone is like collected all stage 3, 4s and compared them to normal healthies, but there are variations of that I have certainly seen over and over again. And I think that's one thing that, for example, Grail did well. From the very beginning, we called it the cancer, initially called it the cell-free cancer genome atlas, but the idea was, across centers, reduce pre-analytic variability, look at the population as a whole, the intended use population, and start out in on the right foot with the samples that we're generating.
You mentioned it's an extreme case, but how often is that? Obviously, I'm not asking you to put a number on it, but is that something that's happening in early stage companies that they're setting themselves up with? And then if they do, as a follow-up question, and they go down that road, when does that become a problem that ultimately blows up and goes, whoa, what have we got here? Because it's not, do you know what I mean? Like, how long can that road be?
Yeah, so it does happen frequently um, because of monetary constraints, and like they think, okay, what this money that we have, this partner has said that they can give us the samples so that we can start getting an early signal. But they have to remember that that early signal might be a completely um, inconsistent signal and can take them down the wrong path. So I think that happens quite frequently when companies think about how to spend the limited cash that they have. Um, and I mean, it there have been companies who've done that and burned through a lot of cash and a lot of time. So it's hard for me to say. I mean, it's not like I work for all the companies that are out there, so it's hard to say, but it does happen frequently.
Wow.
Yeah.
That's pretty wild, isn't it? That's pretty crazy. Is that a pressure thing? A pressure to perform? A pressure to show some sort of result?
Yeah, I think it's to show a result. You know, the attractiveness of genomic diagnostics has been that they don't necessarily have to go through the same lengthy development cycle
Hmm.
that devices and therapeutics have to through the
Right.
FDA, right? And so I think that path, and again, this is only my opinion from seeing the past 10, 15 years, is that path seems to like be pushing to be shorter and shorter and shorter and showing more evidence sooner, um, which is, yeah, unfortunate.
Yeah, that's
Yeah.
really interesting. Um, Investors at the moment, because obviously this is a really hot topic in the
Mhm.
industry at the moment, and it's incredibly challenging for many reasons. What are investors looking for when they're assessing these early stage companies? And obviously, you've just mentioned sort of the 3 points that you believe: due diligence, clinically, and also the people side of it, getting those things lined up and correct.
Mhm.
What are investors looking for when they look at these types of companies?
Well, they are looking for proof points to show that, where the company should show that they have that they have some discrimination power in at least one clinical context. I think I believe they're also looking for a team that is adaptable. At least I hope hope they're looking for teams that are adaptable and that are working well together. I have heard like examples of where they said, "Oh, your team seems to be working really well together." So I think that's important. But yeah, I don't. I mean, I would say there's that, and then presumably, they're looking for some component of AI because every pitch deck has AI in it. So I would think that maybe they're looking for that as well. I don't. Again, I think I mentioned it earlier. I think the term AI in these decks are maybe overused and misused. Many of the models that are used are typical statistical models, right? Gradient boosting and penalized regression and all of those kinds of things. There are a few that are using more sophisticated, what I would call maybe bordering on generative AI modeling, like variational autoencoders. But for the most part, yeah, I think they're also looking for maybe AI to be used.
So let's dig into this a little bit, Tara, because I feel like you've got some thoughts around it. So AI in diagnostics, and as you it's a hot topic. We speak to founders, we speak to VCs. There's quotes as such of like 75% of all capital for 2025 is reserved for AI
Mhm,
companies, whatever that
mhm.
means. What's your thoughts on it? Because you just mentioned that actually what could be dressed up as AI was just something that was called something else 5 years ago and was still doing the same job. So what's your perspective, especially as a statistician, on AI in diagnostics, where it's being misrepresented, but also where it's actually being really well used and will fuel, some really exciting things for the future?
Yeah, I think, so I mentioned a few techniques, um, in order because I would say that there's an interest in interpretability and like the biological context. And so some of the truly AI or more AI type models like the variational autoencoders don't lend themselves as much to that kind of interpretation. Uh, but there is a place for modeling like that. I would say that again, the majority of the techniques are machine learning or statistical models. A place where I've been using AI, and I would say generative AI a lot, is around coding. So uh, in the old days, you would have a statistician who specifies, okay, we would like to have these analyses run, and then you'd have to write all these detailed specs of the type of model you want to run and how to massage the data and all of this, and then you would hand that off to a programmer, and all of that. And then the program would have to interpret your specifications and then run that, and then the statistician would review it and then make the other changes. And statisticians could do some analysis on their own, but it wasn't like for me it was never my like strong suit to do the hands-on
Yeah.
programming. But now that there are all these tools like ChatGPT and Claude and like even Cursor, which is specific for coding, which Cursor is also kind of bordering on agentic AI, where it can make, like, if you give it a high level problem, it could take multiple files in order to reach an overall goal.
Mm.
But even these generative AI tools are making my work, and I think much of the this kind of development work in bioinformatics and in statistics much more efficient. I would say I'm at least, I don't know what, 20x more efficient at
Really?
generating analyses than I was. It could be that my bar was really low before, and so now it can only go up. But yeah, it does make it makes teams more efficient and effective, and I think it makes statisticians and data scientists more effective because we can run through things much more easily on our own and yeah, generate insights quicker.
Not to be that guy, but the cliche conversation at the moment is, how does it affect people's jobs? Um, is it better to have 20 times Tara's, or is that 20 people's jobs that we've just lost that used to do your programming? No, but on a serious note, is that sort of multiplication of your experience, right, is awesome. But does that mean the future of statistical analysis completely changes because of AI and the jobs within it?
Probably. I mean, I think of, for example, if we were to do a device filing, right, with the FDA, and I actually heard that the FDA is using some sort of AI tool as well. I'm not as familiar with that. I'd be curious to hear more about that. But you have to create what they call TFLs, tables, figures, and listings, and they all have to be in a certain format. And it takes a lot of like processing time for programmers. They're large CROs that have templates and they have programs that go against those templates. And then you have statisticians specifying the analyses, and then oftentimes there's like some level of misinterpretation. So you go back and forth and back and forth. And so I think that entire process, which is really cumbersome and time consuming and costly, most certainly should be compressed in terms of the number of people having to work on it, the quality. You'll get better quality
Mm.
because there isn't all these steps in the translation, and there's and you'll get it faster. So I think, yes, that entire process should change, and at Tiger Team, we're looking to change that process.
Yeah, super interesting, isn't it? But also, I mean, there's so many positives to take from that someone like yourself, with your experience, can produce so much more with the use of this as a tool. Um, but I also find it interesting that you said that, a lot of this stuff has been around and is now just being called AI, when actually it was part of, big statistical models that was being done for a long time. It
I
makes.
think that's just an old statistician speaking, maybe. I don't know.
But to be honest, it's not the first time I've heard that at all. Someone said, well, it's just software or it's maths. People just call it AI.
Mm,
So just peel it
yeah.
back.
Yeah.
And so, what should early stage companies be doing right now to improve and make sure they're setting themselves up for better long-term opportunities, but also ensuring that they are attractive to investors and so forth? What do you think they should be doing early stage to get their ducks in line and be facing the right direction?
Yeah, I think it comes back to what we talked about, the technology, the clinical, and the people. Just the technology, like really understand, do the right experiments early on to understand the performance of your technology in a particular clinical unmet need. So do those experiments on, like, for example, I gave the simple example of the depth of the sequencing, maybe something around, like, even like if your test is meant to work on fresh samples, but you've banked all these frozen samples, understanding what the implications are if you were to get fresh samples, for example. Um, Technology level experiments early on. And then the second is, don't fall for convenience samples. Design the right studies. They're clinical studies where you're enrolling patients and you're getting samples from those patients, but you have quality clinical data. You controlled the pre-analytic variability, and you've controlled for other confounders in the population, such that you aren't, going down a road that then requires you to totally backtrack and start from the beginning again and go down another path. And then I would say the third thing is the adaptability. When you see the results, continue to evolve the thinking around what is the best use of this technology, what is the best way to interpret the results and return useful information to patients and physicians. Um, and always think about patient first.
Yeah, I love that. That's the genomic health coming out in you, is it?
Yeah.
Thank you, Tara. That's great. Looking forward, objective outlook on the future of diagnostics and genomic diagnostics. You feel like that? I know it's because it's a tough year, right? And it's been a little bit tough for many companies. We've seen a lot of companies, fall away. Unfortunately, funding is still hard, although I actually think there's a little bit of optimism over the last couple of months in terms of the some of the raises that have been announced, and we are trending up. But people don't like optimism; people like pessimism. But what's your objective outlook in terms of where we're going over the sort of next 12, 24 months, and what you're looking forward to?
Yeah. So I think, like I mentioned, there's some companies that are companies are doing, between 1 and 2, maybe some are doing all 3 well. But those that are doing maybe 1 or 2 of these well might be looking to partner with other there are a lot of companies out there, right? So maybe there's an opportunity for the merging of minds and people and ideas and technologies and data sets, right? So I would love to see the merging of the different companies with the different pieces that they do well and coming together. I don't know if that's a reality or not, but that is something I would love to see. That way we could bring more products to patients by bringing the best of the different companies together. I do think that the cancer genomic diagnostic space seems pretty crowded. I'd love to see other clinical indications get more visibility, like mental health, and maybe inflammatory and metabolic diseases. With all the GLP stuff out there, I don't know if there's an opportunity for genomic diagnostics in the GLP space. I haven't quite identified an opportunity yet, but I'd be curious to see if anyone comes up with something that could be helpful to patients there.
Yeah, interesting. Why is it that mental health, in your opinion, is so far behind oncology?
That's a good question. I mean, in terms of like biological specimen biomarkers, there's the blood-brain barrier issue, and then also the subjectiveness of the assessment, right? Mental, like for something like cancer, you can look at the tumor tissue. There's like actually something physical, right? So I think that there's those 2 kind of barriers to development of genomic diagnostics, and that's actually why we're focused at Pandora on these behavioral and social biomarkers, because our theory is it's not necessarily biological that's going to drive this, but there's so much out there in terms of behavioral and social biomarkers, right? There's eating, sleeping, exercising, there's movement, right? If you track GPS, then if someone's isolating, and that's a signal. How much time people are spending on social media and on their phones and gaming, and so there's so many of these biomarkers that could be used to predict changes that are outside of like genomics.
Yeah, awesome. Tara, I love your perspective on the Pandora side of the mental health side. Interesting. I had a conversation with a company who are in genomic diagnostics for mental health, and are finding that countries in the Middle East this is one of their sort of top 3 priorities for the country, and therefore they are actively looking at diagnostics companies to come and set up labs in the Middle East. And if you do that, they then give you funding, so there's access to more capital, and big push, and actually trying to draw American companies to go over there and set up and accelerate their development over there. So but obviously a shame that a company would have to go to the Middle East to feel that they can get better access to capital just to develop the product that they're so passionate about. But Tara, thank you so much for that. This was awesome. Super insightful, super detailed as well, in terms of what you're seeing in those early stage companies and what they're doing well and what they're maybe not doing well, but also the outlook on the market and where it's potentially going. Thank you very much for coming on.
Yeah, thanks for the opportunity. I can talk about this stuff all day, so thanks.
There you go. Thank you, Tara.